cardiovascular research. My name is Salona, and I'm a student here at SSR Medical College, and this is my colleague Anik. We will be your MCs for this session. Yesterday was a very insightful day, and today we will continue the discussion, starting with the first session centered around cardiovascular risk factors. The session will consist of 15-minute presentations, where each presentation will be followed by a 9-minute question session.
So to begin with, I would like to introduce you all to our very first year of Session 4, Professor Derek Hossenroy. He's an eminent researcher and an academician, professor in cardiovascular and metabolic disorder program at Duke-NUS University of Singapore. He is also professor at Institute of Cardiovascular Sciences, University College of London. Currently, he's the director of National Heart Research Institute Singapore and has over 338 peer-reviewed articles since 2002. He has also guided 11 PhD students and 16 MD students under his wing. He has also earned a total research grant income in Singapore over $17 million. Can we have a huge round of applause for Professor Derek Hossenroy?
Our second chair is Professor Derek Yellen, a professor of molecular and cell biology at the University College London and director of the Hatta Cardiovascular Institute at UCL and UCL Hospital. He was program director for the NIH UCLH BRC Cardiovascular Society from 2013 to 2017 and past vice president of the British Cardiovascular Society and chairman of the Cellular Biology Working Group of the European Society of Cardiology. He's a professor of medicine at the University of Cape Town, South Africa, as well as the University of South Alabama, USA, and North China Cole Medical University. Presenting Professor Derek Yellen. Our first speaker for this session is Professor Sandrine Lecure. She trained as a doctor in pharmacology at the University of Burgundy, France, thereafter obtaining a PhD in cardiovascular physiology, following which she moved to the University of Cape Town, South Africa as a postdoctoral fellow. She is currently a professor at the University of Cape Town, leader of the Cardioprotection Group, and deputy director of the Cape Heart Institute, University Cape Town, South Africa. Her research group focuses on the delineation of novel intrinsic cardioprotective signaling pathways that can be activated under stress conditions. Fellow of the European Society of Cardiology, past treasurer of the International Society for Heart Research, the European section. She is the founder and past president of the South African Society for Cardiovascular Research, presenting Professor Sandrine Lecure.
Yeah. Good afternoon, good morning, everyone. There's not much jet lag. I'm not sure why. First, I would like to thank the organizers for giving me the opportunity to be here today. It's truly an honor, and I'm just amazed about the kind of hospitality of all the local organizers on the island. So today, I wanted to talk about high-density lipoproteins and is there any role for the HDL in cancer and anthracycline-induced cardiac toxicity. So, as you probably know, the anthracycline doxorubicin is a very effective chemotherapeutic drug against a wide range of cancer, including breast cancer, but unfortunately, it suffers from a side effect where cancer survivors, many cancer survivors, will develop congestive heart failure due to myocardial damage, and we refer to it as DOX-induced cardiac toxicity. The incidence of cardiac toxicity in the cancer patient is very high, and the cardiotox registry, for example, from Spain, reports as much as 37% of the patients and receiving anthracyclines that will develop anthracycline-induced cardiac toxicity. The SAT-RCD study is a study conducted in Uganda and reported more than 44% of the patients suffering from cardiac toxicity. So there are multiple risk factors that will favor the cardiac toxicity, and these include, for example, hypertension, diabetes, and ethnicity, which are factors that are very relevant for the Mauritius. So the mechanisms of cardiac toxicities are multiple and includes, but are not limited to, oxidative stress, inflammation, apoptosis, mitochondrial dysfunction. It is very important that we understand the mechanisms of cardiac toxicity so that we can develop early biomarkers and intervention therapies to protect the patients against DOX-induced cardiac toxicity. One of the particles that have been of interest to us is the high-density lipoprotein or HDL. You all know the HDL particles for their role in the reverse cholesterol transport, where they will transport the cholesterol from the periphery back to the liver for degradation. And many epidemiological studies have reported an inverse relationship between the HDL cholesterol concentration and the risk for cardiovascular events. However, this traditional curve has been a challenge in the past few years, where in fact this relationship might be much more complex and would be actually a U-shaped association between the HDL cholesterol and the adverse cardiovascular events. Indeed, individuals with the HDL cholesterol lower than 30 milligrams per deciliter or higher than 60 milligrams per deciliter had an increased risk of all-cause mortality and cardiovascular death or non-fatal myocardial infarction, suggesting that too much HDL cholesterol is actually bad. There is actually a large heterogeneity of the HDL particles. These HDL particles are made of more than 200 functional lipids and 7 groups of proteins, and their functional properties is not limited to the reverse cholesterol transport. They have high antioxidative, anti-inflammatory, anti-apoptotic, or cardioprotective properties. There are multiple particles of HDL which can be divided function to their size or density into HDL subclasses. And we usually refer to the large, intermediate, or small HDL subclasses. But what is important is that these different subclasses have different compositions and as such have different functionalities or properties. And it is suggested that the smallest subclasses of HDL particles have a greater cardioprotective property. Here, for example, the biological activities of the different HDL subclasses when looking at the cholesterol efflux capacity, the antioxidant capacity, the antithrombotic or anti-apoptotic capacities, clearly shows that the small HDL have better protective biological activities compared to a large HDL subclass. Our colleagues in Geneva have used an isolated cardiomyocyte to demonstrate that HDL protects against doxorubicin-induced cardiac toxicity. So they incubated the cells with doxorubicin, and they could see an increase of the DNA fragmentation and a decrease in the cell viability. But if the cells were incubated with doxorubicin in the presence of HDL isolated from healthy patients, they could see an improvement with less DNA fragmentation and an increase in cell viability. This is the reason why we came to the hypothesis that breast cancer patients receiving DOX chemotherapy may see a change in the HDL particle profile from a healthy profile to a dysfunctional HDL profile, and this may contribute to the cardiac toxicity that is observed in the patients receiving doxorubicin. So to assess this, we conducted a sub-study from the SAT-RCD study, the one in Uganda that I mentioned earlier, and we used the serum from 34 female breast cancer patients that received anthracycline therapy. We looked at the HDL subclasses before at baseline and at completion of anthracycline therapy. And what we observed is that actually this anthracycline therapy was associated with a decrease in the intermediate subclass of HDL, while there was a tendency to increase the large subclass of HDL. We did echocardiography in these patients, and we could see an association between the HDL subclasses and cardiac function, a positive association. So our data suggests that anthracycline therapy in breast cancer patients alters the HDL subclass distribution, and this effect was associated with cardiac dysfunction. But one major limitation is that it's difficult to see whether this association is actually due maybe to the cancer evolution or is it due to the drug itself. This is the reason why we moved to an animal model. And in this animal model, we had mice in which we inoculated breast cancer cells. And then once they developed the tumor, they were subjected to a treatment of doxorubicin for 5 weeks. We did echocardiography, and we had different groups where with or without the tumor and doxorubicin. So first, we could see in our model that the doxorubicin treatment reduced the tumor volume, which was expected, but we also observed that the doxorubicin reduced the radius strain of the anterior wall. When looking at the subclass distribution, we could see that the tumor was associated with a reduction process with a shift of the HDL subclasses to large subclasses. Interestingly, doxorubicin on its own was actually increased more subclasses HDL. We then look at the function of HDL and whether they're anti-inflammatory and antioxidant. To assess the anti-inflammatory function of the isolated HDL, we measured the PAF-AH activity and then the pyroxenase activity to look at the antioxidative function, which is an enzyme, antioxidant enzyme, specific to the HDL particles. We could see that the PAF-AH activity was increased in the presence of the tumor, while the tumor and doxorubicin combined together would reduce the antioxidative activity of the pyroxenase enzyme. We managed to observe association between the cardiac abnormalities and the HDL subclass and function with a radial strain anterior wall that was directly associated with intermediate HDL subclasses and the radial strain anterior wall that was directly associated with the pyroxenase activity. So all this data clearly suggests that both breast cancer and doxorubicin treatment will mediate changes in HDL subclass distribution and functionality, and that this effect was associated with cardiac abnormalities. So these are associations, but we were really wanting to know, does this shift in HDL subclasses or does this shift in HDL function really contribute to the cardiac toxicity? Are the HDL still functional? So to answer to that question, then we moved to a cell culture model, and we had H9C2 cardiomyocytes that were treated with doxorubicin. And we looked at the cell viability in the presence of doxorubicin alone, and we could see that doxorubicin, as expected, was reducing the cell viability. But then we introduced the presence of HDL particles that were isolated from our mice with a different, that received a different treatment. And we could see that when the mice, we gave the HDL particles from the healthy control mice, we could restore part of the toxicity that was observed with doxorubicin, which was not the case if we were incubating doxorubicin in the presence of the HDL particles isolated from the mice that received doxorubicin or the tumor. To summarize, there is increasing evidence of a U-shaped curve between plasma, HDL cholesterol, and cardiovascular adverse events. HDL, there is a very large heterogeneity of the HDL particles that can have different size, different composition, and this may influence their functional activities, including the antioxidant, anti-inflammatory, or vasodilatory activities. The cancer and the doxorubicin was associated with a shift in HDL size, a change in HDL composition, and I didn't show all the data, and a change in HDL function. Cancer and doxorubicin shift the HDL size and function, and this closely related to the cardiac abnormalities. And the HDL particles that were isolated from mice that received either the cancer cells or doxorubicin failed to protect against toxin-induced cardiac toxicity, therefore suggesting that a change in HDL size and function may contribute to the development of cardiac interaction in cancer patients receiving doxorubicin. I would like to thank all the members that contribute to that work, with a special mention to Carmelita Adman, who actually is a PhD student, and she did all the experiments that are presented to you today, and she's going to submit her PhD in the next few weeks. And you can see a picture of her here because last week she won a competition at our university, which eventually gave her a grant to continue her research by doing lipidomic and proteomics from the animals' blood samples, because the idea is to try to understand what are the components in the isolated HDL that do contribute to the change in the functionality of the HDL. Thank you very much.
Thank you very much, Sandrine, for that excellent talk. Any questions from the audience? One from us, John Wayne.
Wonderful talk and also very nice findings on the HDL. I'm just wondering, for your patients and your animal study, did you use free dogs or doxil?
Free dogs.
Free dogs. And for patients as well? Okay, that's a bit surprising because I know in Singapore, mostly, the hospital only provides the doxil, with a liposome formulation of the dogs, right? It could reduce, the cardiac toxicity very significantly.
I will have to check on that for that. I will make sure of it.
Yeah, because we did a similar study for another, antioxidant compounds this last 2 years, and we initially we just bought the doxil from the hospital, but in mice, we hardly see any toxicity effects on the heart. And to the end, we realized we used the liposome formulation. I think this is something maybe for you to consider, and especially for the patients. Thanks.
So what we've seen with the cardiac toxicity is that the first signs are the cardiac strain. If we look at the ejection fraction, it comes much later. So we really, now in our model, it was differences in the cardiac strain, but not the ejection fraction. Also, it's a little bit more complex than that because, most of the animal models do not include the cancer component. They test doxorubicin without the cancer component. And if we look at the ejection fraction, we could see the toxicity in a group that received only doxorubicin, but we couldn't see the toxicity in a group that received doxorubicin on cancer. And if we look at all our data altogether, actually what seems to happen is that the cancer induces a stress. And it's actually accelerated as a conditioning protocol because the cancer actually will prepare a certain level of protection against the doxorubicin treatment. And this is what we could observe by having the 4 groups, and very few studies include the cancer into the model.
Yeah, that's a very good point. So actually, we also do not see much difference in ejection fraction. Instead, we measured the cardiac diastolic dysfunction. So in this case, we measured the myocardial performance index.
Yeah.
In that way, it's much more sensitive than the ejection fraction, especially in this case.
Okay, I think there's maybe a comment, Malcolm. Is it related to the last comment? Maybe Malcolm first. Oh. Thank you, Sandrine. That was very interesting. One comment, first of all, in the UK, for cost implications, the majority of patients do not get the liposomal doxorubicin, despite our pressure, perhaps, on our colleagues in oncology to use it more. Nevertheless, within a group that we studied fairly recently, not with breast cancer, but with cancers that require significantly higher doses, excuse me, of anthracycline therapy, the incidence of cardiotoxicity immediately is about 5 to 10%. But you're absolutely right. The difficulty clinically is a much later progression. So within 12 months, you begin to pick out changes in cardiac function. Yes, that's a comment, but just a brief question. There is a lot of evidence coming out, and this is a comment rather than a question. A lot of evidence that exercise therapy before, during, and after exposure to anthracyclines or any other therapy improves outcomes. And it's an interesting supposition. One of the things exercise does is to alter content and composition. It's interesting to have a hypothesis to hang the benefit of. Thank you.
Yeah,
so quickly, maybe from the first comment, the toxicity in the women's forest, the STAT-RCT study that was conducted in Uganda looked after 6 months. And most of it was subclinical cardiac toxicity. So that is combining toxicity and subclinical toxicity. And for your second comment, yes, definitely exercise. And we're very interested to continue and testing the effect of exercise because we've done a study of the exercise in diabetic patients where we saw that in diabetic patients we have a shift in HDL profile. And as soon as they exercise, we reverse that shift to the normal profile. So we're actually hoping that exercise would be a good way to shift the HDL profile back. Thank you.
You showed the interrelationship between doxorubicin administration and switch or changes in the subclasses of HDL. Now, what's the mechanism behind? One aspect I'd like to bring in is the birth of HDL starts when these protein tablets, so to speak, adhere to the HDL receptor ABC A1 transporter that shuffles lipids into these protein tablets, which then blow up into lipoproteins. Might this be a reason, so the effect on the ABC-A1 transporter of doxorubicin that would also alter the different distribution of the subclasses, perhaps?
Okay, so first all what I'm going to say is hypothetical, and I wish we would have the answer. But what we need to think is that the HDL particle is actually a vehicle that transports and release proteins and lipids. And we need to see it as a very active component. And I'm not sure whether the change is happening within the particles that are circulating, or whether it's happening within the formation of the particles. And that would be different. And I must say, for now, we've looked at the alpha-lipoprotein A, we've looked at a few components that are specific, usually from one of the other type of HDL subclass, such as tyrosine 1-phosphate. We've seen some differences, but I think this is where we need to go for a metabolomic study, so that we can pinpoint which of these components are actually modified.
Okay, thank you, Sandrine. For the sake of time, I'm afraid we have to move on, so maybe you can ask questions to Sandrine later. Thanks very much, Sandrine.
So thank you, Professor Loco, for those captivating words. Now, moving forward, I would like to call a second speaker for the session, Professor Hayes. She graduated as a medical doctor from Medical University of Pest, Hungary, and specialized at clinical laboratory diagnostics and clinical pharmacology. She has published 255 papers, has 9,151 citations, and multiple patents. She has defended 24 PhDs under her supervision, and she's the founder and stakeholder of Pharma in Vivo Limited and Group 21 in Hungary, Algonis GmbH in Austria, and she's the scientific advisor for Pharma Novo Limited Sweden. Today, she will be presenting on the topic chronic cigarette smoking induced cardiovascular pulmonary comorbidities in a mouse model, potential role of metroproteases. Please welcome her on the stage with a few notes.
Okay, now it works. So sorry. So I'm very honored to be here because I'm not a cardiovascular expert. I'm a neuropharmacologist, neuroscientist, basically working on pain and inflammation and the sensory system and the interactions between the sensory, vascular, and immune systems. How I actually got in touch with cardiopulmonary vascular comorbidities is that the lung is very densely innervated by sensory fibers, and they regulate the inflammatory mechanisms, although it is not painful, but these sensory nerve-derived neuropeptides play a very important role in different mechanisms related to inflammation of the lung. And because the lung is very closely related to cardiovascular processes, the idea came that we might have a chance to get some new insights into cardiopulmonary comorbidities. So this is what I'm talking about today, and this is our new campus of the medical school in Page, which is located in the south of the country. It looks like being at the periphery, but indeed it is the middle. So the story I'm trying to show you today is related to chronic obstructive pulmonary diseases. COPD is a very common disease, which is related to progressive persistent airway flow limitations and enhanced chronic inflammatory mechanisms and processes in the airways. And it is indeed significant because it's still the third leading cause of death. I just checked it yesterday, and even in this year's database, this is so. And it develops almost in 1/5 of chronic smokers. Of course, smoking is not the only reason. There are different other factors leading to COPD, but that's the most common cause. And there is no causative treatment, no cure, and the progression cannot be stopped, only slowed down. So it's actually a huge social economic burden. We have very limited information about the mechanisms and the comorbidities, and it's partially because of the complexity of the processes and the interactions between the neural, vascular, and the immune systems. So actually, I think there is a huge importance for having translational animal models. The mechanism is actually related to all these complex processes
And we indeed have quite a complex, increasing knowledge about the pathophysiology, but still we don't know what the key mediators are and what the targets can be for future therapies. And it is because of the lack of translational animal models. The only authentic model is the chronic cigarette smoke exposure-induced model, although there were several other attempts. And there are some chronic cigarette smoke exposure models, but the problems and the limitations are that they all apply different protocols. They use different animal strains, even mouse strains, which react differently to the stimulus, the same stimulus, the same irritant. And there is the lack of longitudinal self-control design studies. And this is what we came across when first wanted to design a study to see the mechanisms. So therefore, the first aim of ours was, and I'm going to show you the data regarding to that aim, to set up a model which uses a chronic cigarette smoking-induced mouse model and characterize this as much as possible. And once we have it characterized, we can say that we have a model in our hands, and maybe we can test some kind of potential new therapeutic pathways. So that was the aim, and this is the protocol we used. We used 6 months whole body cigarette smoke exposure system. We used the smoke exposed mice as smoking, and the intact, that refers to the non-smoking healthy controls, which were the same age, studied the experiment at the same time, but they were not put into the whole body smoke exposure system. We use male mice, but I know now it's a very important issue to use also females. So we are doing some further studies with females, just right now in the future. And then we expose these mice to whole body cigarette smoke in a chamber twice a day for 30 minutes when the smoke was coming with the Kentucky Research cigarettes standardized, and they were in the smoke for 30 more minutes. This is considered not a heavy smoking, but a moderate smoking, but it's difficult to estimate, of course, and reflective to humans. And we did 2 functional measurements. We measured the cardiac functions by transthoracic ECG, and we also measured the respiratory functions by restrained whole body plethysmography. And at the end of each month, we sacrificed certain groups of mice at the end of each month, and we tested the lung histopathology, vascular immunostaining and scoring, then inflammatory cell counts in the glomerular lavage fluid. We did lung structural alteration studies with in vivo micro-CT. We did also some cytokine profiling, both in the lung and the heart. And we also measured the matrix metalloproteases, MMP2 and 9, because there were some data already that it might have something to do with COPD. So that was the protocol, and I'm just showing you some data we got. Some of these are published, but some are still going on, and we also have some new insights which are not yet published. So regarding the cardiac functions, we noticed that the ejection fraction decreases after actually 5 months of whole body smoke exposure significantly compared to the intact non-smoking healthy controls, which is the most important sign for systolic dysfunction. But we also observed the same thing for the diastolic functions, which is significantly decreased only after 5 months. And also this right ventricle systolic function, this decrease with annular plane, that decreased a little bit earlier, even after the end of the 4th month. So the message from this that you have to expose the mice for quite long to cigarette smoke in order to have any cardiac functions, but it is detectable. So if you want to study this kind of mechanism, you have to wait for 4 or 5 months. Then we also measured the respiratory functions. This slide seems to be busy. I just selected some of the airway function parameters we measured. But you can see here that, for example, airway resistance, the end expiratory verve, the end expiratory pause, the tidal mid-expiratory flow and expiratory time, and the Stephenol index, which is a ratio of the inspiratory time and the expiratory time, and the inspiratory time, they are all the markers in the mouse model for respiratory dysfunctions related to COPD. They all decrease by the end of the 6 months. I'm not showing you the whole process because of the lack of time, but before, it is actually not that prominent. There is a gradual decrease. It's getting significant also after 4 months. And this is quite peculiar because for the humans, you would expect something different. But in the mouse airway mechanics, that's what you find in this model. And because of the whole body plethysmography, these are the characteristics changes for the lung. Then for the histopathology, after 1 month, you only see an edema formation around the vessels and the bronchi. There is no inflammation yet. Inflammation peaks after 2 months. You still have the perivascular peribronchial edema, and you have a lot of inflammatory cells around the bronchi. So it's located around the perivascular peribronchial space. And after 3 months, the inflammation is spreading into the interstitial regions. It's getting differently located. And then later, after 5 months, the inflammation is decreasing and emphysema is developing. So this is what we can find, and this can explain also the functional changes. And these are all the scorings which were done by the pathologist colleagues. They also look busy, but here you see the edema formation, which peaks after 1-2 months, and then declining. Here you see the perivascular inflammation, which is peaking very, very much at the end of the 2nd month. And this is important because I'll show you in the next slide that you can only detect the inflammatory cells in the bronchoalveolar lavage at this time point. So I'm just pointing this out. And the inflammation is getting into the interstitial space. It's actually still there after 2-3 months, but then again, you can detect it later. And the epithelial damage is peaking by the end of the study, which is related to the emphysema formation. And these are the inflammatory cell counts in the bronchoalveolar lavage. And this is what I already indicated, that all the inflammatory cells, including the granulocytes, lymphocytes, macrophages, they can only be detected significantly in the lavage fluid at the 2nd month. And this is not surprising because later the inflammation is spreading in the interstitial areas. So if we are really interested in this mechanism, in the inflammatory mechanisms, you have to do the smoking process at least 2 months, not really later. So not all the different mechanisms can be studied at the same time. Then we were interested in what happens at the vascular level, and in collaboration with Professor Schultz and Schirmuli in Giessen, we did these measurements and measured a marker of vascular smooth muscle proliferation, which is called the proliferating cell nuclear antigen, which is related to the vascular smooth muscle proliferation. And these are just semi-quantitative scorings, but actually this peaks after 4 months, and later on it's actually declining because of the structural damage of the lung. And there is a clear difference, so clear increase. And this is related to these vessels, which can be categorized to 3 size categories. Those are the smallest ones, the medium ones, and the bigger ones. And because it seemed to be interesting, we also measured the medial wall thickness of these small and relatively small pulmonary vessels, which suggest fibrosis and remodeling of the vessels. And we found that it already increases after 1 month of smoking, and it stays increased compared to the intact non-smoking groups, particularly in the small vessels, the smallest category, and also in this medium category, but not really in the bigger category. So actually, vascular remodeling and fibrosis, it's not directly related to the inflammation. Definitely not, because it's already earlier. So these are parallelly going mechanisms, but not directly related to the inflammatory process. And then this is what we saw on the micro-CT. These are the parameters that the micro-CT measures. Actually, this is the parameter what the micro-CT measures. There are several others, very interesting ones, but I just highlight this one, this LAA-TLV ratio, which is the low attenuation per total lung volume ratio. It is showing us the emphysema formation, and it is clearly seen that it is increasing. This might be due to the edema formation, not to the emphysema, but the edema, but then it's stabilizing, and emphysema develops after 5 to 6 months. This is a rather sensitive marker, but we also did histopathological quantification of the mean linear intercepts, which is also related to emphysema, and it seems to be much more sensitive. So even earlier, this can be detected, but these are much more similar to what we see actually in the clinical practice. So long exposure is needed in order to get emphysema. Then we measured the cytokine expressions, and this is also a busy slide. I just want to highlight that in the lung, these are microarrays showing us complex cytokine expressions. And I just want to highlight that in the lung, we have much more cytokines expressed as compared to the heart. We also did it on the heart. In the heart, actually, almost selectively, one adhesion molecule called the soluble intercellular adhesion molecule, the cytokine 1. This is almost the only cytokine which is increased after 6 months significantly, which might have to do something with the cardiac deterioration. But in the lung, there are many, many cytokines, much more after 2 months as compared to 6 months. And it's not really important to check what they are, but using the software, they are clearly IL-1 related cytokines. So the IL-1 related pathway is involved in the pathophysiological process. And we also measure the MMPs, MMP2 and 9. They are increased in the lung after even 4 or 5 months. But I'm just showing you the 6 months data. So the two isoforms, the MMP2 and 9, both significantly increase, related to the activity, the gelatinolytic activity in the lung. So therefore, because MMPs seem to be interesting and we had the proof of concept that they increase, we also checked as a second step after having this model characterized whether these MMPs have any functional role in this smoking-induced cardiac comorbidity in the mouse model. And we treated the mice with a non-selective MMP inhibitor, doxycycline, which is a tetracycline antibiotic. And if you use it in a sub-antimicrobial dose, it's long been used for that purpose orally in a drinking water. So it's appropriate for long-term administration because you don't have to inject the animals for 6 months. So they were administered this in the drinking water for 6 months, and we tested what happens in response to the treatment. And this sub-antimicrobial dose doxycycline clearly prevented the smoking-induced cardiac function impairment. This just shows the 3 and the 6 months data. So actually, ejection fraction reduced after 3 months, doxycycline restored, and also after 6 months, the deceleration time also the same thing, smoking reduced, doxycycline restored. In this tracheostomy annular plane systolic function also, there is a significant decrease and restoration by doxycycline. And again, it improves the chronic smoking-induced deterioration of the pulmonary functions after 6 months. So yeah, just these are the last slides. There is a reduction in smoking, and doxycycline restored all these respiratory functions that I already showed you earlier, which are characteristic of the pathophysiology. These are the histopathological slides. You see the huge inflammation here after 3 months, doxycycline restores, and the structural changes after 6 months. Well, there is not such a spectacular change, and this is confirmed also on the histopathology that after 3 months, the inflammatory mechanisms are reduced by the small dose doxycycline, the edema, the perivascular inflammation, and the interstitial inflammation significantly. So as a summary, I can say that I hope I could convince you that this is a good translational mouse model. It doesn't matter what you want to study at which time point, but this is the first evidence that this comorbidity can be modeled in this system. We found characteristic pulmonary inflammatory processes which are time-dependent. Unlike humans, the inflammation and the structural damage do not occur simultaneously, but as a stepwise mechanism, but the COPD-like real structural and functional changes develop after 4 months. In the lung, we have a candidate, maybe this soluble, this ICAM, this adhesion molecule might have a role in the cardiac deterioration. IL-1-driven cytokine cascade and MMPs might also have some roles in the lung and also in the heart. And I hope that it was also interesting to you, that it was interesting for us, that this sub-antimicrobial dose doxycycline is a promising candidate for the cigarette smoke-induced heart and lung function impairment because it can inhibit both. Of course, these MMPs are not as fashionable recently for novel therapies as microRNA or some other kind of strategies, but still I can say that this might have a relevance in this condition. Thank you very much for your attention, and I have.
Thank you very much, Susanna, for that great talk and a careful characterization of that COPD model. Any questions from your audience? Malcolm?
Very much. I'm not sure the question's worth all that effort. Anyway, we'll go ahead. Thank you very much. That was good. You admitted right at the very beginning that you're not certain what components of cigarette smoke. Could this be completely non-specific in terms of just an inflammatory stimulus to the lung? The reason I'm asking is that I'm feeling wheezy and a lot of cough from all the pollution produced by motor cars on our way between our hotel and here. And in many countries, of course, that is being addressed. And there's a huge scandal in our own country, whereby most motor cars are being banned from London in an effort to improve it. So do you think this would be applicable to other insults to the lung rather than direct smoking, which is a diminishing problem in our society, for good reason?
Yes, that's exactly a good point. And there are experiments using different pollution complexes on the mice, but that's even less standardizable. So you are absolutely right. Smoking is not the only cause of COPD, as I mentioned, but it's one of the most common causes. I'm pretty sure it's not specific. I mean, these mechanisms are not specific to smoking, and it's possible to model. I mean, even the air pollution is possible to model in animals, but you have to be even more careful. Here, at least, you have a research cigarette. You know what is in there, and you can do the analytics, and you can refer to that, and that works. But meanwhile, there are so many other irritants which act basically on the sensory nerves directly by activating the sensory nerves, and also on the immune cells by being presented to the immune cascade members. But as for modeling, this model seems to be more relevant. And of course, this is a whole body smoke exposure, so this can be criticized because in animals you can also use the nasal smoke exposure, but for that you have to restrain the animals, which is also stress and glucocorticoids modify the mechanism. So this is not easy, but you are absolutely right with your question because that's true.
A final question from Lavendra. Lavendra.
Nice talk. So I just wanted to ask you, like, if you did an insult like a bleomycin, for example, for IVF, so after 3 or 4 weeks, the lung starts repairing itself. Now, if you don't just do any more insult, so did you follow up what happens after 6 months if you stop giving this passive smoking?
Yes. We haven't checked that, but this is indeed a good question, and we got that from the reviewers earlier, and we still have this question, and this is in a kind of future plan because it's relevant, but I cannot tell you the answer for that because we haven't tested.
And another question, like, how do you think that MMP2 and MMP9 changes in the lung is affecting cardiac?
Well, we also checked it in the heart. In the heart, MMP2 is expressed, and we measured that at the mRNA level. There is an overexpression at the mRNA level, but not at the activity level. So we think that it's not the pulmonary, or at least not only the pulmonary, but also the heart's own MMP2. But it is again difficult to prove whether it is MMP only in the lung and that the lung changes affect the heart indirectly through the MMP pathway, or there is a direct MMP-related process on the heart. It's very likely that it's indirect because of some other data that we had in vitro, but you cannot exclude the direct effect on the heart either.
Okay, great. Thanks very much, Susanna.
Thank you, Professor Hayes, for your sharing your work with us all. It is my pleasure to introduce our very own professor in the Department of Pharmacology and next speaker, Professor Indrajit Banerjee. Being one of his past students, I can confidently say Professor Banerjee has a passion for teaching and has actively been involved in the teaching and learning process of pharmacology for the past 15 years. He has research interests in clinical pharmacology, pharmacoepidemiology, systematic review, meta-analysis, psychopharmacology, drug utilization studies, medical education, and COVID-19. He has won the prestigious CEA Prize in Neuroscience 2013 from Kerala, India, and the Best Paper Award for his research at the International Conference on Research Methodology and Scientific Research in India. He has published 126 papers in various index journals, 6 books, and 4 chapters to his credit. He has presented more than 150 research papers at various international conferences. And recently, he was nominated as a keynote speaker in the second International Asharaka Medical, Nursing, and Health Sciences Congress, Turkey. Welcome, Professor Banerjee.
Good morning, everyone. So I will talk today about the pharmacological intervention for long COVID and the cardiac manifestations of long COVID. All of we are here, we have gathered for this conference. This is our SSR Medical College. Let me tell you about something about the SSR Medical College. SSR Medical College is the first medical college in this island, and we are serving the medical students since 1999. So it is a 24 years we are here. So before I proceed with the long COVID, let me, in very brief, I will just explain that what happened during COVID-19 pandemic in Mauritius. So that would be in very brief, COVID-19 in paradise. You know that Mauritius is a beautiful country, is well known for the beaches, and we are all gathered here. This is a medical college. So this is the data from WHO about the present condition of COVID-19. I won't be talking about the figures because nobody is interested on the figures nowadays. So let me quickly go to the timeline of COVID-19 in Mauritius. So you see, the first case was reported. They were having a travel history from United Kingdom, and they were cruise ship workers. So it was 3 cases that was reported. And the first case that was reported on March 18, 2020. So this is the first wave in Mauritius. So after the first wave, there were about 335 cases were detected until June 3rd, 2020. And total 10 deaths were reported. And there was no community spread of COVID-19 was noted after that. So how the government of Mauritius worked together to stop the spread of COVID-19. As soon as it was detected, the first case was detected, the next day itself, the country, all the schools and colleges were closed. And the country went to total complete sanitary lockdown from March 23rd, 2020. And the first 2 deaths were reported in March 25, 2020. On 2020, June 2nd, there was no community transmission was seen. This is all about the first wave. So after the detection of the COVID-19 in Mauritius, and again the country reopened and everything became normal. But again, just after a year after the detection of COVID in Mauritius, the second wave started here. So Mauritius lost its status, safe status, and a cluster of cases were reported. and it was detected in a fruit importation enterprise. From there, a lot of clusters were detected in others, some of the schools here, and also some of the large family gatherings. After that, again, country went to the second lockdown. After that, slowly all the process become normal, and currently we have, from the beginning, we have about 309,869 confirmed cases of COVID-19 were detected, and 1,054 deaths were reported. This is data from WHO. At present, do we have any COVID cases in Mauritius? If you see, there are about 90 new cases that were reported in October 13. And one patient is admitted in the ENT hospital. The ENT hospital that takes care of the critically ill patients. They require ventilator support. So during that lockdown, we published few papers. This is regarding not cardiology actually. This was related to medical education, and we published about the effect of lockdown on medical students here, on the psychological and education impact of lockdown on medical students. And also, we have published this paper also. It is published in the African Health Sciences. It is about the exceptional route of transmission that I mentioned for the second wave. It was through importation. That was also published in this journal. We have published a book also on overview of COVID-19. This is with one of the ex-student of SSR Medical College, who is currently a doctor, Dr. Jared Robinson. And we have published a book chapter on post-COVID syndrome and long COVID. So actually, what is this long COVID? So let me ask a quick question to all of you. How many of you have suffered from COVID? Yeah. So anybody has suffered with forgetfulness? After that, forgetfulness, because I got that clinical feature, forgetfulness and fatigue. Anybody suffer from fatigue after getting the infection of COVID? No, so it is actually long COVID. So we have published a paper on the treatment part of long COVID also. Right, so what is long COVID? Long COVID is described as a persistent long-term state of poor health following an infection with COVID-19. So it has got multiple synonyms. Long COVID is also called as post-COVID syndrome, also called as post-COVID-19 condition. So let me tell you about the definition given by WHO. This is the WHO definition given by Delphi. So just I have highlighted some of the key words or key points that will tell you what is that long COVID actually is. So it occurs in individual with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained by any alternative diagnosis. So common symptoms include fatigue, shortness of breath, cognitive dysfunction, and others, and generally have an impact on everyday functioning. Symptoms may be new onset, following initial recovery from acute COVID-19 episode, or persistent from the initial illness. Symptoms may also fluctuate or relapse over time. So what are the signs of symptoms? It is a multisystemic nature and has got a wide range of clinical features. What you see here, that it mainly affects the respiratory system. So it is presented with cough, dyspnea, fibrosis, interstitial thickening, renal system, the cardiovascular system, and the nervous system. That I was telling about the forgetfulness, the brain fog, that is very common feature that is seen in long COVID. So brain fog, prolonged fatigue is very important. So this is a cardiovascular conference, and you see what are the cardiovascular clinical features that can be seen here is a chest pain, vasculitis, coagulopathies, palpitation, myocarditis, abnormal ECGs, and increasing propofol. So you see, I have mentioned about that it affects multiple system of the body. So you see, it affects by the AC2 receptor and involves multiple organs of the body. So this is a study that was published by Duke-NUS. They have conducted a research on an online survey on 81 million patients on about 273,000 COVID-19 survivors, among which it was found that they were having at least one symptom of COVID-19. So they were having either restlessness, fatigue, chest pain, headache, GI symptoms, myalgia, cognitive symptoms, anxiety or depression. And how long the patients can get these features of long COVID? According to the definition of WHO, they are saying that we can get up to 3 months. But this is a study that was published by Hannah E. Davis. They have found that this can go up to 35 weeks also, means around approximately 9 months. So frequent symptoms were fatigue, post exertional malaise, and cognitive dysfunction. Next, I will talk about what are the long-term complications of COVID-19 in cardiovascular system. The patient gets myocarditis, that is very common, myocarditis and fibrosis and arrhythmia. So myocarditis, very common, that is a post-COVID complication of COVID-19. So the clinical features are sudden onset of chest discomfort. There can be chest pain also, chest segment abnormalities, arrhythmia. There can be alternation in the blood pressure. The diagnosis of myocarditis can be done by echocardiogram motion abnormalities. There is increase in the N-terminal pro-brain natriuretic peptide. There is increased level of cardiac troponin and left ventricular dilatation can occur. Other cardiac complications are myocardial interstitial fibrosis. So it can be diffuse or localized in nature. Usually what happens, the necrotic cardiomyocytes are replaced by fibroblasts because of myocarditis, microinfarction, and vasculitis. Followed by, there is one more mechanism due to cytokine storm and immune cell infiltration. These fibroblasts can be replaced by myofibroblasts, resulting in matrix modeling, which may cause fibrosis. The other complications that are seen are cardiac arrhythmias, among which the sinus tachycardia was most commonly found in the patient for long COVID complication. So actually, we don't have any treatment for long COVID. There are some drugs which are on clinical trials. And what are the drugs on clinical trials or which research are going on? I'd like to highlight it on. So the pharmacotherapy of long COVID. So we have some treatment that is undergoing clinical trial or it is under experimental basis. That is hyperbaric oxygen therapy. It is found to be effective in the treatment of reducing the fatigue in COVID-19 patients. Montelukast, that is a leukotriene antagonist. Dupirfenidone, that is an antifibrotic drug that is helpful in treating the respiratory condition in COVID-19. This one, we have vitamin C supplements. So it has got anti-inflammatory role, immunomodulatory role, so helpful in fatigue. Even a high dose of vitamin C is effective by immunomodulating and pro-inflammatory response. So breathing exercises and singing exercises also are useful in treating the respiratory condition. That is also under trial. So probiotics can be given to normalize the composition of gut flora to reduce inflammation in GIT. There were some clinical features that I mentioned in GIT. So probiotic supplements can be given to them. This terolimab and tocilizumab, these are IgG4 monoclonal antibodies. These are also found to be effective in long COVID. Then we have melatonin and adaptogens. So adaptogens are type of herbal preparations that also can be useful in the treatment of long COVID. The first drug is montelukast. So montelukast is a leukotriene antagonist. So a trial is going on this montelukast, a double-blinded placebo-controlled drug trial, phase 3 trial. 284 patients has been registered and they are receiving 10 milligrams of montelukast orally for 28 days for the treatment of respiratory condition in long COVID. Vitamin C supplements. So there is a study done by Volbrack, about 720 to 720 participants, what was found that there is a marked reduction in the FACT score in the patients after giving vitamin C supplements. And it can be used as an adjuvant drug in the treatment. Leronlimab, this is a monoclonal antibody, IgG4 monoclonal antibody, which is a CCR5 receptor antagonist. And also, what was found with this drug, it can cause normalization of the downregulation of receptor that is found in the patient. So again, clinical trials are going on this drug, on leronlimab. Melatonin, as we are aware that melatonin is a drug that is helpful for sleep, actually. Sleep wakefulness and maintenance of sleep wakefulness. And this drug is, melatonin is obtained from the pineal gland and it acts on the melatonin receptor. So this drug is also found to be effective as an antioxidant, but also improve the sleep pattern in patients with COVID-19. So adaptogens, these are Halber preparation. Again, on this also a randomized control trial is going on. Adapt 232, 100 patients were receiving adaptogens. So this is found to be effective for the improvement of renal function, physical performance, capabilities, and fatigue. To conclude, long COVID is a long-term complications of COVID-19 and are a serious complication of SARS-CoV-2 virus. So further study and research on long COVID and its implication is vital. These are my references. This is a place in Mauritius. This is mainly I kept this for the foreign delegates. You can visit this place. This is in Albion, and it's a very nice place to visit. Thank you.
Thanks very much, Indrajit, for a very nice overview of COVID in Mauritius and the long COVID. Any questions from the audience? Paul, please. Thanks.
Actually, I am not a cardiologist, but I will try with that. Long COVID on the patients, those are already having comorbid condition of cardiovascular disease, you are saying. When we have done this review, actually, we didn't got this type of information that the studies that was done with cardiac complications, actually. Because when we collected all data, that was during that time, it was quite new. And that's why I mentioned about that more studies are required to come to any conclusion.
Okay, thank you.
Maybe Paul, just to add, actually in Singapore, we're going to be looking at this, how patients who have heart failure or pre-existing ischemic heart disease, how do they do post-COVID? So we'll be looking at this in Singapore. We'll be able to answer that. I think question from Umesh.
Yeah, I just wanted to add a comment on the question asked before. We've been seeing lots of patients of COVID at hospital, especially who come with cardiovascular complications. In fact, except for the amount of thrombus with acute myocardial infarction that we have seen in our cath labs, we've never seen thrombosis like this. I have never seen thrombosis like this. So one of my patients that I remember, he had an acute MI where his right coronary artery was having chunks of clot. And at the same time, the LED in the mid part was having huge chunk that I've never seen before in my experience. We left that patient for a week. He was on all the anticoagulants and anti-lytic types of treatment. After a week, when we took up the patient, the thrombosis was still the same. But we stented at that time because in the beginning, we didn't stand the patient, but a week after, the clots were almost the same. But except for that, we have not seen patients with heart failure in my practice who got COVID. I got COVID twice, a year apart, and I still go to the gym, I do all my exercise and everything. But when I got it, it was a bad one. So I don't know how far this long COVID is true, but personal experience, everybody got COVID in my home. We are all very fit, but it depends from patient to patient.
Thank you. Any other questions? Okay, if not, thanks very much, Indrajit, for that great talk.
Thank you, sir, for holding our exciting topic. Next, I would like to call Professor Paul Yin to speak as our first speaker for this session. And Dr. Yin currently is professor in the Cardiovascular and Metabolic Disorder Program, Duke-NUS Medical School, Singapore. He obtained his MD from Johns Hopkins, completed residency in internal medicine at the University of Chicago, and endocrinology fellowship training at NIH. He was formerly assistant professor at Harvard Medical School and associate professor of medicine and pharmacology at Johns Hopkins University. He is also the recipient of the 2020 OTA Nagasaki Fujifilm Prize, and his team's research has laid the theoretical foundation for the use of liver-selected thrombolytics and vitamin B12 folate therapy for the treatment of Nash. And today he'll be presenting on the same as topic cardiac effects of non-alcoholic steroids. Please welcome him on stage.
Yeah, thank you for your kind introduction. I also want to thank the organizers for making me an honorary cardiologist for 2 days and be able to participate in this wonderful meeting. I think this is the fifth meeting that I've been to over the years, and I've really enjoyed it. I've really learned a lot. I also want to just acknowledge the host here and the students who I really enjoyed talking with about the research and posters that really felt the excitement and enthusiasm for research that they had. So I'd like to just tell you a little bit about what we do and then one direction that we started recently for our research. I originally was going to talk about some work related to spermidine and protein translation, but I think I'm going to make it slightly different because I think it may fit the topic talking about perhaps be more interesting to the general audience here. So the title really is pretty much the same: development of a model for cardiovascular complications associated with Nash. And Nash is an acronym for non-alcoholic steatohepatitis. Actually, it's a pretty new disease. It's really first discovered about 40 years ago, and was probably around for a long time. And at that time, it was really considered cryptogenic steatohepatitis, and they were found in patients that did not have any viral disease or alcohol intake history. So it was not known what the cause was. But interestingly, patients were obese. Most of them had diabetes and cholestasis, which still is the phenotype that patients with Nash have. And when we talk about Nash, we're really talking about a whole spectrum of diseases, going from hepatic steatosis, which is really the most common form, and then about 10% of patients develop steatohepatitis and Nash, and then these patients, small percentage will develop cirrhosis. The problem is that about 30% of the world population has had liver. So starting out with a fairly large, huge economic, so it's about 10%, and then just maybe another 10%. Still talking about hundreds of thousands of people that are hundreds of cirrhosis. It's already probably the major cause of transplantation. Viral hepatitis. the prevalence of NAFLD is really pretty much distributed throughout the world, and it's found in developed countries, maybe less so in Africa, but that may also be a study. But certainly in Asia, we have, and even in countries like very poor, because when there are changes in society, when people become more sedentary, move to the city, they no longer have the lifestyle and increase in obesity and diabetes, in fact, so around the world now, this is really, the only thing you have to offer is study proven size, weight, control. So there are no drugs, so there are some on the rise. So one of the things that endocrinologists are very interested in, I first looked at 14 years ago, try to look at what thyroid hormone does on fat metabolism in the liver. And really, our work over the years examined the effects of thyroid hormone on autophagy, particularly lipoprotein, so ways that the liver can use autophagy to take fat from fat process. Use it for the life. The triglycerides converted to glycerol and free fatty acids, and then used as fuel. And we saw that this also increased mitochondrial activity. That's something well known for a long time, and also increased mitochondria. So all of these things we found all seem to lead to a decrease in acidosis. Several other groups did find that thyroid was very potent reduce acidosis, animal models of Nash. Then we also did a human study, diabetic patients that had fatty liver, and again using toxicity, we saw there was a significant reduction in the fat content. And, oh, okay, sorry. And then that also we've done studies then to look at inflammation and fibrosis in Nash. And I think a lot of our work provided some of the theoretical groundwork to develop a liver-specific thyroid hormone receptor beta thyromimetic, which go to the liver. And it turns out that the thyroid hormone receptor isoform that's in the liver is TR beta, and this probably has more selectivity for the liver and less toxicity. All right, you may all know that with thyroid hormone excess, like hyperthyroidism, atrial and ventricular tachycardia is always a problem. So this kind of compound has been developed. There's huge pharmaceutical companies I have no interest in that have developed them, and they're probably going to be approved by the FDA in maybe in the near horizon. And this was a study that was done in the Lancet that looked at one of the compounds. So we've also done some work with vitamin B12 and folate, and we found that there's hyperhomocysteine associated with non-alcoholic fatty liver disease. Although we know that this increased cardiovascular risk is stroke, this was kind of a novel finding. And really, most of the homocysteine that is measured in blood is made in the liver. And what we found is that increase of homocysteine in the liver actually leads to a novel post-translational modification called homocysteinylation. And one of the proteins is a protein involved in the fusion of the autophagosome with the lysosome called factor 17. We're doing some preliminary work. We found that in the heart itself, there seems to be some proteins that are homocysteinylated. We don't know the identity yet, and whether that plays any role in the heart function. We're trying to also look at working with Derek and a few other people, looking at atherosclerosis. What are the cells that might have hyperhomocysteine-related proteins? Whether that might be potentially one reason. And then the other thing we found was that there's decreased protein translation in NASH, and across quite a number of different proteins. But one group was mitochondrial proteins, and we found that spermidine has low in patients with NASH, and by giving spermidine replacement, you can actually increase the post-translational modification using spermidine, called hypothenation of the translation factor called BI5A. This actually improves the mitochondrial protein translation, increases mitochondrial activity in the liver. We've done some work on the heart, so I was going to really talk about that. Maybe that's the more with the data. But instead, what I want to tell you, the work has been done along the similar lines in terms of how might the liver affect the heart. I mentioned homophosphorylation, and I also mentioned the effects of spermidine on protein translation in the heart. So thinking about this more, we know that NASH actually associates with quite a few other non-liver diseases. So one is the sarcopenia, chronic kidney disease, and then the major cause of death from NASH, not liver failure, but actually cardiac disease. So this is just a chart of some of you just saying that right now the liver is known to make all sorts of proteins that essentially could affect functions of the tissues, particularly in the context of NASH. So when we think about what was going on, we're wondering what could be causing effects from the liver to the heart. And certainly, metabolites like homocysteine, chemicals like spermidine, something diet, but also made by the liver, low, maybe that is affecting protein. There are certain proteins that have metabolic effects at times, they could be affected. And then certainly exosomes and the metabolism itself, that's cardiotoxicity. Most of these patients are diabetic, resistant, high free fatty acids, that also that increased cholesterol and glycerol that are being produced by the liver and by or possibly inflammation, maybe the fact that we have inflammation in one tissue kind of primes the whole body, then has or perhaps the production of certain cytokines, interleukins, TGF beta, could affect fibrosis. These are all open questions we want to probably try to look at over the next few years. And so when we look at NASH effects on the heart, we're going to ask ourselves, what, how does NASH affect manifestation? And we wonder, how can these extrahepatic tissues damage their NASH? We know that they play a role in morbidity and mortality. And how does NASH then affect that genesis, heart, muscle, also the kidney during NASH? So what I'd like to share with you is just some very preliminary data. The model is valid. Temporal changes in heart and muscle diagram of NASH. So we've used this model quite extensively for 3 or 4 years. And we put these mice on Western diet fructose diet. And these mice, by 8 weeks, developed hepatitis, and then 16 weeks they developed mild NASH, and then longer developed more severe. And we've actually gone out now to 48 weeks. So end-stage liver disease, cirrhosis, diabetes, pretty high incidence of hepatitis. So when we look at this model, we try to look at effects of inflammation over here, the marker inflammation, fibrosis over here. And what you can see is that it's a pretty steady increase that occurs over time, which is consistent with the increase in that is occurring. And if you look at the staining, it's a really simple method that pathologists use to diagnose that. You can see that at 8 weeks, a fair amount of hepatocytosis, that increases more. But then there's also evidence of fibrosis, inflammation, and much more severe evidence of fibrosis. And these areas once become called ballooning. It's not that well understood, but it's considered a hallmark of Nash. So we then turn our attention to look at temporal changes in the heart during Nash progression using this particular model. So if you look at this, what we saw is that in the heart itself, we start seeing evidence of inflammation around 30 to 16 weeks. So it's actually later than when we saw Nash with the liver. And interestingly, looking at kidney and muscle, we see very similar phenomena. So we think that Nash actually occurs quite early, not that long after the patient's OD starts developing symptomatology. You want to talk about more inflammatory conditions, metabolic syndrome. It seems like Nash occurs first, and then these other conditions occur later, based on our animal data. And then fibrosis is really relevant. We already saw evidence of fibrosis in the liver. It seems it really doesn't happen in the heart. So, and if you look at the proteins, we get fairly similar findings. In other words, some of the inflammation markers trending up, significant only activity. Same thing, PTS, fibrosis. You only see the protein expressed with activity. And when we actually start looking at serial echocardiogram in our mouse model, we're actually extending out to 48 weeks and waiting for that data. But what we can see is that there's not much effect on fraction short, but it starts decreasing here at 32 weeks. So this is the end diastolic diameter minus the systolic diameter. And then what we see here is not much change in the technical study. And then here we see that there is an increase in LV mass, very little decrease in cardiac output, so far during here. And just wanted to say that this picture looks a lot like the heart failure with the ejection fraction reserve. And then I'll just mention quickly the muscle. They're showing very similar state phenomena. Here is inflammation, fibrosis markers. Then again, Nash preceded these effects in the muscle, just like it did in the heart. And then we did several different types of testing for the muscle with life, one with good strength. So here you can see that there is a decline. We had around 24 weeks, some of the testing. So in summary, this preliminary data, we think that we have, based on maybe 5 or 6 studies now, quite a good model of Nash that resembles human condition. And we found inflammation and fibrosis and good thoughts something in the heart and skeletal muscle that they occur a little later. And we think that cardiac change resembles peptide. Our preliminary data strongly suggests that actually exceeded the pathological feedback of cardiac process. These data raise the question whether Nash causes this patient heart. So does it go through immune-related response, or is it some factor treated by heart? So we're going to compare these findings using dietary models of Nash with this dietary model, genetic model of Giessen that do not appear Nash. Look at the cardiac phenotype and see how much of this can really attribute to Nash itself, how much is attributed to Giessen. So This work was done by a PhD student in our lab right now, and the work on Nash was done by quite a few different postdocs or now faculty. So this is our group here, and just want to say thank you to Singapore.
Thank you very much, Paul, for that great talk. Maybe I can just start with an opening question quickly. I think it's quite challenging to know whether it's the Nash that comes first and the cardiac dysfunction, right? Because it could be that the diet also has a direct effect on the heart. And it could just be that the heart is less susceptible than the liver. And that's why it starts off in the liver and then the heart. Well, how could you tease apart to see if it really is sequential?
So,
Great, thanks, Paul. A question from Sean?
I was just wondering the rationale for including the fructose in the diet. Is it trying to mimic an unhealthy human diet, or is it to induce diabetes, or what? How do you see it functioning?
Okay, a final question from Peter.
Yeah, very nice talk. You mentioned that you have also some research on vitamin B12 and folate. Yeah, so and just a question that there was a trial called VitaTox trial with 8,000 patients, and did you check these clinical trial data if this population had less Nash? Yeah.
What that does first, almost to Duke-NUS, and I so there along and for
Okay, thanks very much, Paul.
Thank you, Professor Yin, for enlightening us with your presentation. Now, our fifth and final speaker for this morning, Dr. Azhar Khan. He graduated from the University of Algiers in 1992, specialty in cardiology in 1986, and he has set up the cardiology services and the cardiology yin in Dr. Jitu Hospital, Port Louis, and Flack Chong Hospital. He's also the consultant in charge in cardiac unit at SSRN Hospital and the member of panel for the preparation of the clinical guidelines for the management of coronary heart disease in Mauritius and clinical guidelines for the management of hypertension in Mauritius. Today, he will be presenting on the topic combination therapy in hypertension, the tried and steady. Please welcome him on stage with a huge round of applause.
Good morning. Thank you very much for this kind introduction. And I thank on behalf of the Cardiovascular Society, the organizing committee of this event, to give us the opportunity to present a study we published last year. Now, this study involved two sub-Saharan countries, islands in the Indian Ocean, Madagascar and Mauritius, where we recruited patients with hypertension. It was an observational, multicentric perspective to evaluate the efficacy and tolerance of association of perindopril, indapamide, amlodipine on blood pressure control at 1 month and 3 months after treatment initiation in ambulatory patients for at least 4 weeks. It was conducted between June 2019 and February 2021. 198 patients were involved in this study and recruited by the different specialties. The main objectives of this study was to evaluate the evolution of systolic and diastolic blood pressure in order to obtain targets below 140/90 and below 130/80 in this hypertensive population, and also to evaluate tolerance reported by the patient and perceived by the treating physician. The inclusion criteria: the patient should have been diagnosed for more than 3 months as being hypertensive. The blood pressure should not be above 150/95. This criterion is linked to the choice of recruitment of patients with comorbidities, but without very high blood pressure figures, and to take into account the indication for the fixed combination as a substitution in patients already controlled with the 3 doses of the same molecules, perindopril, indapamide combination, and amlodipine, taken simultaneously at the same dosage. And the treatment by the fixed combinations ranged between 1.25 milligrams to 10 milligrams for the maximum posology we used. And it was initiated in ambulatory care since at least 4 weeks. Now, these are our exclusion criteria: contraindication to the active substance and one of the excipients of the medicinal product. Pregnancy and lactation also was considered. Secondary hypertension was excluded, as well as orthostatic hypertension. Patients should not have been hospitalized, and cardiovascular events in the 3 last months also were excluded. Another clinical trials involvement also, these patients were excluded. Disabling illnesses such as dementia, inability to cooperate as well. Type 1 diabetes and neoplastic diseases also are excluded, and clinical signs of ischemic heart disease were excluded. These are our patient characteristics. We had slightly more female patients than male patients, and the average duration was about 7 years. And half of the population was in the group 40 to 59 years, and half above 60. And many patients had cardiovascular risk factor comorbidities. Now, nearly 2/3 of the patients were either overweight or obese. 1/3 were practically obese patients. And 20% were smoking. We had a family history of cardiovascular disease of 42%. 46% of diabetes as a family history. And our patients, 43% were diabetic, with about 1/3 is already had a left ventricular hypertrophy. Renal disease, myocardial infarction, angina, congestive heart failure were other comorbidities present. About 13% of patients had already a stroke. And this was the study plan. After recruitment, at the initial visit, systolic blood pressure, diastolic blood pressure, heart rate, and body mass index were measured. And after 1 month, these measurements were repeated as well as the tolerance reported by the patient and perceived by the physician. At 3 months again, these patients were reviewed, and the tolerance by the patient and perceived by physicians were documented, as well as the measurements of the systolic blood pressure, diastolic blood pressure, and the heart rate. And this was the different doses we used in this population. 50% were on high dose already of the fixed single pill combination therapy, perindopril, indapamide, and amlodipine. Now, this hypertensive treatment were modified during the course of the study. And of course, we had 13 modifications at 1 month, with 19 additions. Tableau therapy were add-on, or a centrally acting alpha-2 agonist methyl dopa, or another small dose of amlodipine if the patient was already on 5 milligrams, or spironolactone were added on. And some patients benefited by a reduction in the posology as well as the fixed combination therapy. At the end of 3 months, there were 2 modifications, and there were 13 additions. And these of the 13 additions, 9 patients were already on the maximum dose of the fixed combination therapy of perindopril, indapamide, and amlodipine. And they had an add-on of it, tabloca, methyl or small dose of amlodipine. Now, the data collection involved 3 measurements were taken for the blood pressure. The patient was in sitting position of 4 to 5 minutes rest. At 2 minutes interval, we took the blood pressure, and it was repeated if the difference of more than 10 millimeters of mercury between the 2 readings. We use mainly an electronic or sphygmomanometer, aneroid Cardiovascular. In Madagascar, they use some mercury sphygmomanometer. In Mauritius, we practically do not use any mercury sphygmomanometer recommended by the WHO because of the toxicity of mercury. Recorded the measurement, average of the last 2 readings were collected. And also we have the research results, biological results as well, together with the tolerance reported at 1 month and 3 months. Now, what are the results obtained? From the initial visit of the blood pressure, the mean here represented 132.8 and diastolic 82. We had a gradual decline and the figures of the blood pressure, whether systolic or diastolic, reported at the first visit at 1 month and the second visit at 3 months. And this was significant. These changes in the systolic and diastolic blood pressure. And what we obtained was, in fact, after 3 months follow-up, less than 8.5 millimeters of mercury were in systolic blood pressure, and less than 5.4 millimeters of mercury, which reached significance after 3 months of the diastolic blood pressure. So they were significantly lower compared to baseline. And now we decompose into 2 groups. Those who had initially a blood pressure above 140/90, and then we are going to see those above 138. In this group, above 140/90, which comprised 50% of the study population, at 1 month, we have 62.9% who achieved less than 140/90. And at 3 months, 80% achieved the target of less than 140/90 figure. And regarding the newer target established by the different societies and guidelines that we are going to see, less than 138, 41% reached the target of less than 130/80 after 3 months. Therefore, at 3 months, those who had more than 140/80 at the beginning of the study achieved the target, 80% of that, less than 140/90, and 41% less than 130/80. And now the patients, 90% of the study population in this group above 130/80. At 1 month, they achieved 18.5% achieved a target of less than 138. At 3 months, 42.7% achieved less than 138, which was quite significant. And according to the recommendations of 2022 American Heart Association, College of Cardiology, European Society of Hypertension, and European Society of Cardiology. And at the same time, what we noticed while analyzing the different biological characteristics involved in that study, that at 1 month and 3 months, we had a reduction in the heart rate, which was significant. And total cholesterol also was reduced, as well as blood glucose, and these 3 reductions were significant from the initial visit to the 3 months. Tolerance now, whether it is the patient passive or the patient, we had a very good and excellent tolerance of the medication used during that study at 1 month and at 3 months. Very good tolerance or excellent tolerance. Only 9 patients out of the 198 developed mild side effects. Only 2 were fatal. Remember, we were using perindopril and inhibitor. And only 1 pedal edema was reported. We were using amlodipine in combination. So, excellent tolerance is reported at 1 month, either the patients or the doctors, and at 3 months, more than 95% of patients and doctors reported good tolerance. Now I'm going to show you 2 different studies as well. Pioneer study and pain, which involve the same molecules. Now these 2 studies, these patients were under dual combination therapy. Either the inhibitor, perindopril, with indapamide, and they could not achieve the target at that time in 2014, which was established to be below 149. The blood pressure remained high as 160, 93 on average, and they had comorbidities as well. They could not achieve, so there was an add-on of this amlodipine, either in single pill combination therapy or free. And they achieved, at the end of 4 months, 72% had a blood pressure control less than 149. Together with those as well who were with parenteral amlodipine 12 combination and who could not achieve the target. And when amlodipine was added on, either in free pill combination or in single pill combination, they achieved a better control for the blood pressure. This is another more recent study published in 2021. Italian study involving 175 patients, which was a subgroup of another big study, the Belle Rive study, and followed for 12 years. This is our molecule, single pill combination parenteral amlodipine and indapamide, and different from triple combination therapy, either free or in single pill. AC inhibitor, calcium channel blocker, and a diuretic. Angiotensin receptor blocker, calcium channel blocker, and a diuretic, or any other combination. Parenteral resulting new left ventricular hypertrophy was less than the other combinations, as well as major adverse cardiac events, with a p-value of 0.05. What are the key changes in 2023? And the European Society of Cardiology and European Society of Hypertension recommended the target therapy of less than 138. International Society of Hypertension as well. American Heart Association, American Diabetic Association, and many other guidelines involve the figures of less than 138. Nice guidelines said with 149 for training. And the recommended drugs across the board was a RAS blocker with calcium channel blocker and a diuretic. And a beta blocker was added on and could be initiated as per company indications right from the very beginning, according to the European guidelines. And combinations initially would start to initiate our antihypertensive treatment. A combination therapy with a single pill was recommended by the European International Systemic Hypertension Guidelines and the American Guidelines and other guidelines and WHO as well. So these are very important things. And 2023 recently published in the Journal of Hypertension Guidelines for the Management of Arterial Hypertension recommend a single pill combination therapy at any step and initiate the treatment with drug combination therapy in most patients. Monotherapy was reserved for frail individuals, very elderly, or high normal individuals with high cardiovascular risk and low risk hypertension with a blood pressure 159. And beta blocker is back on board now and can be used as monotherapy or at any step of combination therapy. And should the drug combination therapy we do not achieve target in the first 3 months, we can add on a diuretic with a single pill combination. Triple combination, single pill, which is what is recommended by the European Society of Hypertension and European Council. So we will be left with only about 5% of patients who will not be controlled, and this can be referred to the hypertension specialist or add on a spironolactone as another fourth agent. Therefore, the target 130 systolic, 80 millimeters of mercury diastolic in most patients up to the age of 79. Remember, We are in Mauritius with a high prevalence of hypertension, and the curve is practically exponential from different age groups. 18 to 24 and 65 above. You can see when you are 70, you are 70% individuals in this grade group with hypertension. And the worst thing about it is that only half of these patients are treated across the board through the different age groups. And those treatment, only half are controlled. So we have a very big problem in terms of cardiovascular comorbidities. Therefore, this is my take-home message. Start right from the start. Single pill combination treatment is perfect to improve the blood pressure. Preferred use of two drug combination for the initial treatment of most people with hypertension. Single pill treatment strategy with the preferred use of single pill combination for most people. Simplified drug treatment algorithm with the preferred use of esteemed or ARB combined with the calcium channel blocker, thiazide diuretic as the core treatment strategy for most patients with beta blockers used for specific indications. Thank you very much.
Thank you very much, Dr. Azarkan, and congratulations for completing that study. I think for the sake of time, if there's maybe one quick burning question, if not. Yeah.
Can I ask a question, please? Lovely study. I'm going to play devil's advocate, if you don't mind. And my concern is you're saying what needs to be done. And those patients in your study were all compliant. Right? But what happens in the real world? In the real world of Mauritius?
This is an observation of the study.
How do you get?
And this to remind you that this study was not funded by the company manufacturing the product. And this was from the out-of-pocket expenditures of the patients.
No, I'm not worried about that. Yeah. That's fine. The study was excellent. And it showed what you have target you have to achieve.
Yes, in the real world.
Yeah, but how do you achieve that?
Because many of our patients are followed in the public sector as well as the private sector. We still do not have any combination therapy. Not even a dual combination therapy. Say this one, a triple combination.
So it must be better facility.
Can explain, for example, with the results obtained from the study in the same population with a triple combination therapy, why we are not having a good compliance first, adherence and persistence also is a very important factor in the part of the public as well as control.
Okay, great. Thanks very much, Dr. Azarkan. Thanks for a great talk. And thanks to all the speakers in that session, and I hand over to students again.
Thank you very much to Dr. Azarkan for your presentation. To conclude the session, I'd like to call Professor Dr. Hausen-Loy to present the speakers with our certificate. Professor Leclerc. Professor Hayes. Professor Banerjee. Professor Yen. And lastly, Dr. Azarkan. To award our chairs with their certificates, I kindly call upon Professor Claus. Dr. Derek Yellis. And Dr. Holzenberg. We will now have a short coffee break and meet back here for our next session at 12 p.m. Could the moderators, Dr. Yen and Dr. Ferdinandi, please make their way to the poster viewing area? Your coffee will be served to you over there. And everyone is welcome after the coffee session to view the posters. Thank you.